Welcome to this Step 3 review on chronic kidney disease management from roadmap to residency. This isn't a lecture on physiology, it's about how test writers build CKD stems and how you attack them. We'll cover 4 high-yield areas: adjusting medication doses for kidney function, treating anemia of CKD, managing secondary hyperparathyroidism, and knowing when to refer to nephrology. For each, I'll give you the stem pattern, the strategy, and a practice question where we reason through every choice. Keep your review resource and question bank open. Let's start. Here's our roadmap. First, medication dosing. Spotting the stem where kidney function is buried in the labs and the drug is the trap. Second, anemia of CKD. Check iron stores before starting a stimulating agent and never chase a normal hemoglobin. Third, secondary hyperparathyroidism. Read calcium, phosphate, and PTH as one connected story and fix phosphate first. Fourth, referral timing. A handful of triggers. Step 3 expects you to know cold. Between each strategy, we'll do a full practice question. This assumes baseline knowledge from your resources. We're here to sharpen how you take the test. Strategy 1 is the medication dosing stem, and it has a signature. The question gives you a creatinine, an age, often a weight, and buries kidney function in the labs while the drama is in the answer choices. The mistake is reading the choices first, getting excited about a familiar drug, and never asking whether this patient can clear it. Train yourself to estimate the GFR before reading a single option. When a CKD patient is offered a new medication, the test asks one of 3 things: reduce the dose, switch agents, or hold the drug. Metformin, gabapentin, DOACs, and many antibiotics have kidney thresholds where the answer changes. Contrast and NSAIDs are the classic avoidance answers. If you see a CKD patient and an NSAID in the same stem, it's there on purpose. For the actual thresholds, drill the dosing questions in your review resource. A 68-year-old woman with type 2 diabetes and CKD comes in for follow-up. She feels well. Her A1C is 8.1 on lifestyle alone, so she needs a medication. Now the labs, where the question lives: creatinine 2.1, estimated GFR 26, potassium 4.6, normal, which is the most appropriate next step. A. Metformin at standard dose. B. An SGLT2 inhibitor. C. High-dose ibuprofen for knee pain. D. A contrast CT of the abdomen. Notice the stem tempts you toward the elevated A1C and the diabetes drug you know best. Resist that. Anchor on the GFR of 26 first, then ask what a kidney at that level tolerates. Make your choice. Kidney function is the hidden variable. A GFR of 26 is advanced CKD, so every choice has to pass one filter. Can this kidney handle it? The elevated A1C is real, but it's not the decision point. The correct answer is the SGLT2 inhibitor. It lowers glucose and slows progression of diabetic kidney disease and stays appropriate into advanced CKD. When one choice treats the disease and protects the kidney, Step 3 usually wants it. Now, the traps. Metformin at standard dose is contraindicated at this GFR. It's the drug you know best, which is why it's choice A. Ibuprofen is planted harm since NSAIDs worsen CKD. The contrast CT is wrong because there's no diagnostic question and contrast carries kidney risk. The answer is the SGLT2 inhibitor. Strategy 2 is anemia of CKD, with 2 ideas the test returns to. First, a low hemoglobin in CKD does not automatically mean an erythropoiesis-stimulating agent. The stem dangles that agent as the sophisticated choice, but look for the iron studies first. If ferritin and transferrin saturation are low, the answer is to replace iron, not stimulate a marrow with no raw material. Also, rule out bleeding and vitamin deficiency. The order is what's tested. Second, never chase a normal hemoglobin. Stimulating agents are started only when hemoglobin is meaningfully low, aiming for partial correction to relieve symptoms and avoid transfusion, not a normal number. Overshooting raises stroke, clot, and death. Undershooting is safe. When 2 choices start a stimulating agent and one targets a normal hemoglobin, that one is the distractor. Second practice question, a pure order of operations test. A 72-year-old man with CKD and a GFR of 22 has 3 months of fatigue. No chest pain or shortness of breath, so he's stable. Stool is negative for occult blood, so GI bleeding is ruled out for you. Hemoglobin 9.1 with a normal MCV. Now the two values that are the whole question, ferritin 40, transferrin saturation 12%, which is the most appropriate next step. A. An erythropoiesis-stimulating agent targeting a hemoglobin of 13. B. Intravenous iron. C. Transfuse 2 units. D. Oral cobalamin, recheck in 6 months. Ask 2 things. Is there enough iron for the marrow to respond, and is he sick enough to need blood now? Lock in your answer. Read the iron studies first. Ferritin of 40 with a transferrin saturation of 12% is iron deficiency in CKD. The marrow has no raw material, so stimulating it is like flooring an empty tank. Give iron and give it intravenously, because oral iron is absorbed poorly in advanced CKD. The answer is intravenous iron. Now the distractors. The stimulating agent fails twice. Iron isn't repleted, so it won't work, and the target of 13 chases a normal hemoglobin, raising stroke and clot risk. Transfusion fails because he has no cardiac symptoms and no active bleeding. He's been fatigued 3 months, and transfusion risks sensitization that complicates future transplant. Cobalamin fails because his MCV is normal and nothing suggests deficiency, and it parks him 6 months untreated. The answer is intravenous iron. Strategy 3 is secondary hyperparathyroidism. Stop reading calcium, phosphate, and PTH as 3 separate values and read them as one story. The failing kidney can't excrete phosphate, so phosphate climbs. It activates less vitamin D, so calcium falls. The parathyroids sense low calcium and high phosphate and drive PTH up. So the classic panel is high phosphate, low or low normal calcium, and high PTH. Recite that and you'll answer these in seconds. A safety check. If the stem shows high calcium, stop and reconsider, since you may be looking at primary hyperparathyroidism. Treatment sequence. First dietary phosphate restriction, then a phosphate binder with meals, since a binder only works in the gut with food. Use a non-calcium binder when calcium is high. Activated vitamin D and calcium mimetics come later. Jumping to parathyroid surgery in an untreated patient is wrong. Surgery is for failed medical therapy. Third practice question. A 59-year-old man with CKD and a GFR of 24 comes in for routine follow-up. He feels well, no bone pain. Read the panel as one story: calcium 8.4, low normal, phosphate 6.1 high, PTH markedly elevated, low normal calcium, high phosphate, high PTH. You recognize that pattern. The stem then tells you he takes no binder and has had no dietary counseling, establishing he's completely untreated, which is most appropriate. A. Dietary phosphate restriction and a non-calcium binder with meals. B. Referral for parathyroidectomy. C. High-dose oral calcium carbonate between meals. D. Activated vitamin D, recheck in 1 year. Notice 2 choices, push calcium and vitamin D, and the stem never said calcium was low enough to need either. Make your choice. The panel is textbook secondary hyperparathyroidism from CKD. High phosphate, low normal calcium, markedly elevated PTH. He's completely untreated, so you begin at the start of the sequence. Restrict dietary phosphate and add a non-calcium binder with meals. That timing matters, since a binder only works sitting in the gut with the food it binds. The answer is dietary phosphate restriction with a non-calcium binder with meals. Now the traps. Parathyroidectomy is surgical overkill for a man who feels well and has never had medical therapy. Calcium carbonate between meals is wrong twice. Between meals means it isn't binding phosphate, and it loads him with calcium he doesn't need, driving vascular calcification. Watch that timing detail. Activated vitamin D comes later and would raise phosphate absorption when phosphate is already high, and the 1-year interval is a tell. The answer is phosphate restriction and a non-calcium binder with meals. Strategy 4 is referral timing, the most memorizable topic in the unit. Learn the triggers cold. Refer to nephrology when the estimated GFR falls below 30, when there's heavy proteinuria, when kidney function declines rapidly, when potassium is persistently high, when blood pressure resists several medications, or when the cause is unclear. The theme underneath all of them: refer early, because late referral means worse outcomes. Here's the key distinction. Referral is not dialysis. A stem will show a patient who feels well to make referrals seem premature, but early referral prepares them for vascular access and transplant long before dialysis. Dialysis is driven by symptoms, not a number. Pericarditis, encephalopathy, fluid overload unresponsive to medication, and high potassium, unresponsive to medication. A GFR value alone does not start dialysis. Keep referral and dialysis in separate boxes. Final practice question. A 64-year-old man with hypertension and CKD is seen in clinic. He feels well, no shortness of breath or chest pain, so nothing is acute. Now the trajectory, which is the whole question. Over 8 months, his estimated GFR fell from 42 to 27. His urine shows heavy protein, potassium 4.4 and bicarbonate normal, so his chemistry is stable. He asks whether he needs a specialist, which is most appropriate. A. Refer to nephrology now. B. Reassure and recheck in 1 year. C. Place a dialysis catheter and start hemodialysis this week. D. Refer only after he develops uremic symptoms. Count how many referral triggers he's hit, then ask separately whether anything here starts dialysis. 2 different questions. Make your choice. This man hit 3 referral triggers at once. Estimated GFR of 27 below 30, heavy proteinuria, and rapid decline, 15 points in 8 months. Anyone justifies referral, he has 3. The trap is that he feels well, but feeling well cancels no trigger. The answer is refer to nephrology now. Early referral lets the nephrologist plan vascular access, begin transplant evaluation, and slow progression. It's a planning step, and there's still time precisely because he feels well. Now the trap's in both directions. Reassure and recheck in a year is the do-nothing trap, ignoring a 15-point decline. Starting dialysis this week is the aggressive trap. Dialysis is for symptoms, pericarditis, encephalopathy, refractory fluid overload, and refractory high potassium, none of which he has. Referring only after uremic symptoms is late referral, tied to worse outcomes. The answer is refer to nephrology now. Here's the pearl that ties it together. Build a CKD checklist and run 4 checks every time. 1. What's the estimated GFR? Find it before any answer choice. 2. Does every drug survive that number? 3. Are the iron studies present before anyone reaches for a stimulating agent? 4. Do calcium, phosphate, and PTH tell one story? And has this patient hit a referral trigger? That turns a long stem into 4 fast questions. Now the 2 traps. Almost every wrong answer is doing too much or too little. Too much. Starting dialysis in a stable patient, surgery before medical therapy, contrast with no diagnostic question. Too little. Reassurance with a lazy 1-year follow-up, waiting for uremia, ignoring a rapid decline. When stuck between 2 choices, ask which direction each pulls. The correct answer usually sits in the middle, doing the appropriate amount for a stable patient who needs a plan. That wraps up CKD management for Step 3. Lock in the 4 ideas. 1. Find the estimated GFR before evaluating any medication, and remember the drug you know best is often the trap. 2. Check iron studies before a stimulating agent and never chase a normal hemoglobin. 3. Read calcium, phosphate, and PTH as one story, fix phosphate first, and give the binder with meals. 4. Refer early on the triggers, start dialysis only on symptoms. Carry the checklist and the 2 traps into every kidney question. Go back to the CKD and mineral bone disorder sections of your resource and drill these patterns under timed conditions, reading every explanation, even for questions you got right. Visit roadmaptoresidency.com for tutors and advisors. If this helped, like and subscribe. Good luck on your exam.